So hi guys, welcome to our GEP Crash Course series, and we'll be doing an SBA revision session covering all the topics that we've covered so far since the start of the year. So I'm Atch and we've got Emily here as well. So we're both GEPs at George's and we're both F1s now. So I'm in North West London and Emily's down in Exeter, right?
Yeah.
Yeah. Cool. We put our email down there as well in case anyone wants to email us, and got the Instagram QR code there if anyone's got Instagram and wants to follow us on there. And we have uploaded last night's session on YouTube. I'll post the YouTube link in the chat later on as well. Cool, so I guess we can start. So we'll be covering the foundations and the respiratory, cardiology stuff, the GI, renal, endocrine, and all the immunology stuff as well. Cool. First SBA here. So we've got a 33-year-old woman who presents to ED with chest tightening, pain, dyspnea, and she's recently come back after visiting her parents in Australia and is worried about taking too much time off work. On examination, she's obviously in respiratory distress. She's struggling to speak in full sentences. Her heart rate's about 120, her rest rate's 30. She's wheezing and it can be heard from the side of the bed. So what's the most likely diagnosis? So if you can put your answers in the chat.
Sorry, I should probably mute my computer.
Right.
Oh, no, I'm not.
Okay, give it about 10 more seconds, I guess.
So there's lots of B's, a couple of A's.
Okay.
All B, I don't know, lol.
At least they're honest. Cool. So the answer is B. So this is a bit mean. I kind of put a bit of a red herring in here with the whole long haul flight she's come back from Australia thing, just to kind of catch you out. So the key things to look at here is the fact that she's wheezing. She's struggling to actually speak in full sentences right now. She's obviously distressed. Heart rate's up. She's tachycardic. She's tachypneic as well. Her rest rate's up. So that's kind of pointing towards more of an asthma picture and not a PE picture. If it was PE, she'd probably still be able to speak quite comfortably, and she would have more pleuritic pinpoint kind of chest pain instead. Does anyone have any questions? Can you take that as a no? So Emily, it's yours.
Sorry, I muted myself. So a 30-year-old lady collapsed in a supermarket. Blood pressure 80/65, heart rate 110, respiratory rate 25, temperature 37. ECG shows sinus tachycardia. Her husband tells you that they arrived back from Australia last week. Since then, she's been slightly more breathless than normal, but had put this down to being unfit and overweight. She had also noticed swelling in her left leg yesterday and had booked a GP appointment for next week. She takes microgynon and she complains of a pain on the right-hand side of her chest, which is worse when she breathes in. Her pregnancy test was negative and her renal function is normal. What is the most appropriate treatment for the likely diagnosis? A, continuous unfractionated heparin infusion. Consider tissue plasminogen activator. B, warfarin. C, low molecular weight heparin. D, rivaroxaban, or E, aspirin.
Okay, we've got a lot of A's coming through. There's one B.
Okay.
Yeah, mostly just A's.
Great, you're a smart bunch. It's a very hard question. Yeah, so oh, have I got control? Sorry, my technology is not the best. Do you want to just keep control, Ash, and then just the questions for me?
There you go.
Thanks. Yes, so correct answer. So this is, as you have probably identified correctly, this is a massive PE, which means there's hemodynamic instability. And you can see that because she is hypotensive, blood pressure of systolic blood pressure of less than 90. A is exactly copy and pasted from the NICE guidelines. Were there any other answers, or does everyone know this?
It's literally all A's in here.
Cool. Okay. Yeah. So just so TPA is used for thrombolysis, and that would be something that's sort of considered, but not necessarily done. Normal PEs, you use DOACs such as rivaroxaban, and low molecular weight heparin could be used and then switched to a DOAC. But in a massive PE, you need something that works quickly and is easily reversible, and that's why you go for the unfractionated heparin instead, and you can give that IV.
So we got a question here saying, when do you know which of these to use?
So what I was just saying, so the unfractionated heparin is because of the quick action and quick reversal. So basically it works faster, which is why you give it the massive PE. There are detailed guidelines on NICE. I can't tell you, to be honest, exactly what it is, but generally you give DOACs first line. Warfarin isn't really used anymore for PEs. And then, as I said before, so you can use low molecular weight heparin, which might then be switched to a DOAC. The other thing, just quickly, this is a question that they always love in exams. So the ECG shows sinus tachycardia. Sinus tachycardia is the most common ECG finding in a PE. They love this. They love this because you might have heard of S1Q3T3. This weird thing where you get random waves that change in different leads, and you can Google it if you want to see what it looks like, but I've never seen it and it's not actually very common. So sinus tachycardia is the main thing that you're looking for. If it says the most specific thing, then that could be the S1Q3T3 thing. Okay.
Yeah, so the ECG changes are usually when it's quite bad PE and you've got kind of cardiac kind of conversation for it. They have to be like really, really bad to have ECG changes. Yeah.
It's the right heart. It's the right heart strain that causes the ECG changes.
Yeah.
Cool.
Oh, speaking of ECGs, here's one. So you got a 60-year-old man who's got sudden onset of severe chest pain while sitting and reading the newspaper. So the pain is associated with sweating and nausea and has lasted about 30 minutes. What's the most likely diagnosis? And the cardiac biomarkers are within normal limits. You can see a lot of D's coming through.
There's one B.
Yeah, there's one B.
Generally. More D's coming through.
Cool, so D is the right answer. So well done, guys. So the way to kind of differentiate it is the fact that he's technically at rest. He's got no changes in his cardiac biomarkers, so the main thing is troponin that you're looking at. And the ECG's not got that many significant changes, actually. So it's more pointing towards unstable angina. Whereas if it was angina, he'd be exerting himself and then getting the chest pain. So just thought I'd put this in there just to help you identify MIs. So in a normal ECG, you can see your P wave there, you've got your QRS complex, and then you've got your ST segment there, which is normal. In the STEMI, it's this ST segment here, which basically gets elevated, which is why it's called an ST elevation MI and a STEMI. Then here you've got a depression in the ST segment, so it's a non-STEMI because it's not, instead of being elevated, it's depressed. Or you can get a T-wave inversion instead, or an NSTEMI. Then the other key bits to know is the which leads kind of map onto which part of the heart and which vessel it's likely to be. So you've got leads 1, AVL, V5 and V6, which map out your lateral leads, which is your circumflex artery. Then you've got your leads 2, 3 and AVF, which are your inferior leads, which is your RCA, so your right coronary artery. And then you've got your septal and anterior leads, V1 to 4, which is your LAD, so your left ascending. Yeah. So those are the key ones to remember. And if you kind of try and map it onto a picture of the heart, it kind of maps onto it quite well. So that would be where the left ventricle and like septum is. This is kind of where, if you just really have to use your imagination here, this is where the right side of the heart would be. So, and then this is kind of just swinging around, which is why it's on both sides. So you circumflex, so going around the circumflex. That's how I kind of learned to remember it. So the next question here. So during systole, which valves is or are open? The answer is in the chat. Okay, I'm getting loads of B's in here.
Yep.
Yeah. Cool. So it's mostly B's, which is the correct answer. So well done, guys. So this bit here is systole. So that's when the heart's contracting. So at this point here, where it's kind of labeled B, here is where the mitral valve's closing, and the heart is starting to contract. So the pressure starts increasing. At this point, the pressure is still increasing past this, even though the valves are open. So the aortic and the pulmonary valves are open, pushing the blood out of the heart. This is because it's still contracting whilst it's pushing it out. So the pressure is still increasing until it gets to this point here, where my arrow is, where the volumes are not low enough for it to start decreasing the pressure, until you get to this point where the valves close and it start off diastole. So here you have the heart muscles relaxing, and it continues to relax even though the mitral and the tricuspid valves are opening here, and it slowly starts filling. So Emily, it's yours now.
Baby is born. There is some flexion of her arms and legs. Her heart rate is 80 beats per minute. She grimaces as the airway is suctioned. Her hands and feet are bluish, and a weak cry is heard. What is the APGAR score? Try not to look it up. It's a very easy one to Google.
So we've got PCs coming in. Let's give it a bit more time. It's mostly C's that have come in so far. Got 1D.
Cool. So the answer is C. And basically we've got 1 point for each of the different categories. So APGAR stands for activity, pulse, grimace, appearance and respiration. And basically, it's good to know basically that it's out of 2 for each thing. 0 is basically nothing. So activity absent, pulse absent, floppy, blue, and not breathing. So that's the 0. And then the 2 points is normal. So 1 point is kind of halfway in between. So you can kind of work it out without having to know too much about it, what it would be, just by knowing that a normal pulse is over 100 in babies, and then sort of 1 point is a little bit worse. So this baby had flexed arms, pulse below 100, minimal response to stimulation, blue extremities, and a slow pulse. So that's where I've got 1 mark for each thing. So that is 5. Yeah.
So next question. We've got a 17-year-old girl who's brought into A&E unconscious. She's vomited 3 times that morning and had blurred vision and an unbearable headache. On arrival, she was tachycardic and had a funny smell. An ABG was performed. So what does it indicate? So have a look at the table and then put your answers in the chat. I can see a few people putting B in there.
Yeah, lots of Bs.
Literally interpreting it a lot faster than I did when I was in Jet BO1.
Yeah, you're quite a bright group there.
Yeah. Also, mostly B here. So, yep, B is the right answer. Well done, guys. So, where's my mouse? There it is. So, the pH here is low. So, that's pointing towards an acidosis. So, there's a way I remember to kind of figure out if it's respiratory or if it's metabolic. I look at the PCO2. So if the PCO2 is going in the same direction, so as in if the pH is going low and the PCO2 is going low or it hasn't changed, then it's pointing towards more of a metabolic picture. If they're going in opposite directions, then it's more of a respiratory picture. And then you start looking at the compensation. So because we know it's metabolic, we would expect the bicarb to be low and the base excess to be negative. So that's your metabolic acidosis. And the way you compensate for that is using your respiratory system. So then you go back and look at the PCO2. And because that's slightly low, then you would say that it's compensating. Now, to differentiate between partial and complete compensation, you go back, you'll have a look at the pH, and the pH here is still low, therefore it's only partial compensation. If it was complete compensation, then the pH would have resolved. So there should be a table. Yeah, there is a table. So there's a table here which kind of goes through all of these different things. So this patient had a metabolic acidosis. So from the actual text, you probably would have guessed something like DKA here. So as you can see, her pH and the PCO2 was low, and so was a bicarb. Now, this is what you'd expect. If both the CO2 and the bicarb are low and the pH is resolved, then that would indicate there was a metabolic acidosis, but it's been compensated for. And it would be the same sort of picture. You'd have to just like figure out the patterns with the others. So the table's in the slides, so you can have a look at it later on. So the next question. We've got a 35-year-old woman who visits the GP saying she's developed a sore throat, feels weak and feverish, and has been struggling at work. She was recently diagnosed with Graves' disease and type 1 diabetes. She was started on a medication but she also invested in supplements which she read online that would help. The GP diagnoses her with agranulocytosis. Which of the following is the cause of this? Pick your answers in the chat. Just give it a bit more time. Give it about 10 more seconds. I'm seeing a lot of B's in here. Okay, cool. So B is the answer. So well done. So carbimazole is usually used to treat hypothyroidism. So in this case, Graves' disease is basically a type of hypothyroidism. And one of the side effects of it is agranulocytosis, which means you're more prone to getting infections as well because you don't have enough white blood cells being produced. The rest of it, so from C to E, they're all supplements and they're not really going to cause this kind of side effects. In terms of insulin, the side effect you'll look for here is hypoglycemia. If they've taken it and not been eating properly, if they're taking too much of it or something like that, you'd want to watch out for that. And the other thing is if they're not taking it as well, they can go the other way into DKA. Next question here. Got a 40-year-old lady who visits the GP. She has a 6-month history of weight loss despite an increased appetite, increased anxiety, and feels like she's getting hot flushes. She's convinced that she may be going into menopause and is worried. Which of the following tests would be the most useful in finding the right diagnosis? Oh, loads of A's coming through. Yep, so A is the correct answer. Well done, guys. So I've just put this table in here from one of my sessions that I did for you guys before. So she's got some of these symptoms here. So she's got this whole like, she's feeling kind of anxious. You'd also get tachycardia with that too sometimes, and palpitations. She's got this increased appetite, yet she's losing weight. So her metabolism's a lot higher, so she's a lot more hungry, but she's also burning everything off. And then she's getting these hot flushes, so she's heat. It's probably reflective of the kind of the heat intolerance and the sweating that she's probably got here as well. And if it's quite bad, then and it's been long term, she'd probably have developed things like oncholysis, pulmonary edema, and things like that as well. And there's possibility that she might also have a goiter there. Whereas with hypothyroidism, it's the opposite, essentially. And then I've also just put the signs that you'll see in Graves' disease as well, which is a bit more extreme. So next question, you've got a 40-year-old lady, so same 40-year-old lady who's visited a GP. You've done some bloods on her now. So what is the most likely diagnosis here? Yeah. Cool, getting loads of C's coming in. Well done, guys. It is C. So if you look at the table here, so the TSH is really low and the T4 is quite high. So that means that the thyroid gland is producing a lot of thyroid hormone, and then and just remember there's a negative feedback loop, and it's basically telling the brain there's too much thyroid hormone, so you don't need to produce any TSH. So that's why the TSH is low. And the way you kind of identify if it's primary, secondary, or tertiary is you think of the endpoint, which is your gland, which is what's producing the main hormone, which is affecting the body. That's your primary. Secondary is your pituitary, and then the starting point is your hypothalamus. So that's your tertiary. And I've just put this table in here as well, just to help you guys out. Just kind of how to differentiate between the different ones. So Emily.
Okay. A mother brings her 8-year-old son to the GP. She's concerned. So fast. She's concerned that her son is not growing as well as the other boys in his class. He is found to have celiac disease, which immunoglobulin is most commonly involved in gluten sensitivity.
So
yes.
Those of A's before you
quick fire round. Very good. Yes, the answer is A. So IgA is found in the mucosal tissue, so that's saliva, breast milk, nasal mucus, intestinal fluid, respiratory secretions, and it's really important because the mucosal surfaces are the entry of where most pathogens sort of get into your body, and celiac disease is due to the inappropriate adaptive immune response to gluten-derived peptides in the GI tract. And the way I remember the various functions of the different immunoglobulins is that IgG is the most generous, so that's the most abundant. And that's the one that crosses the placenta as well. IgM, this might be slightly more fast stretched, but it's immediate. So I think of immediate with sort of capital M's, which is the antibody that's produced first in an infection. IgA is in the airways and other mucosal surfaces, and IgE is allergy. So that's just the way I remember the different immunoglobulins. Good.
There you go. There's a table there as well.
Oh yes, and here is the table.
Excellent.
So next one, a 40-year-old lady presents with epigastric pain, yellowing of the skin and sclera, and dark urine. Blood tests reveal particularly high levels of conjugated bilirubin. What is the most likely cause?
Got a couple A's already.
Yeah. I'm going to make my questions harder.
Yeah, loads of A's coming in.
Yeah, so the correct answer is A. Very good. Yeah, so to be honest, I know this is a very realistic question, just because we don't really test levels of conjugated versus unconjugated bilirubin, but what we can see is yellowing of the skin, obviously, and we can see whether there's dark urine and pale stools, and those are really important questions to ask, because the conjugated bilirubin, so bilirubin is conjugated by the liver so that it can go into urine, basically, so you can wee it out. So if you've got high conjugated, you've got dark urine. If you've got low conjugated, then you have normal coloured urine, paler urine, and the so yeah, pre-hepatic is high unconjugated. Hepatic, you'd get a mixed picture. Post-hepatic, high conjugated, and that's because the liver is doing the conjugation. Yeah, and so also so with the stool as well. So the stool is kind of usually opposite to the urine. I kind of, the way that I remember it is sort of thinking about the urine, and the stool's just opposite. Yeah. Also, this is a very typical gallstone disease patient. So it's a lady, more common in females, more common in sort of 40-year-old ladies in particular, and epigastric pain is very typical. This is a very typical picture.
Isn't it 4Fs, right? Like,
yeah, I don't.
40 female fetus.
Yeah. I do remember that, but I didn't want to say it. I feel like it's mean. But it does help me remember it, so it is good way to say it. But you can also get thin patients that get bile stones. And men.
Yep.
Sorry, I didn't need to go back. It's me, isn't it? Yes. A 52, see if you can be quick with this one as well. 52-year-old man presents to the GP with a 1-month history of progressive heartburn and dysphagia. What is the most important management?
Got a C, got a B.
Important management.
Got another B. Can you give it a bit more time?
Yeah.
This one's a bit harder.
Yeah, it is actually. I hadn't really read it before I said be quick.
Got a bit of a mix of A and B here.
Yeah.
I think the A's are starting to win.
Okay. So the thing that I'm really getting at here, so 52-year-old man in the GP with progressive heartburn and dysphagia. So dysphagia is swallowing difficulty. If you've got dysphagia, you're less worried about things like you're less worried about things like GORD, or you're more worried about things like cancer. This is one of the alarm symptoms. So the most important management here would be to get an upper GI endoscopy to diagnose that cancer. All of these things could be appropriate, but the thing that potentially would sort of save this person's life first would be the endoscopy to get rid of, or to find a cancer. Go on to the next slide, please. So dyspepsia is a range of upper GI symptoms. I put these definitions in because I always forget the difference between these. So dyspepsia is a range of the upper GI symptoms which are typically present for 4 weeks or more. So these can be abdo pain, discomfort, heartburn, gastric reflux, bloating, nausea, vomiting. They're all, it's a really vague term. And this could be GORD, this could be peptic ulcer disease. Dysphagia is difficulty swallowing. So if this question had said dyspepsia, then the question might be different. The answer might be different, although there still is a sort of an alarm symptom with this man being 52, because he's sort of a bit older, so you'd probably want to do an endoscopy anyway. But the thing that the real alarm symptom here is dysphagia. You shouldn't have difficulty swallowing, and you need to exclude a malignancy immediately if that's the case, unless you've obviously got sort of a sore throat and a cold and things like that. And then adenophagia is painful swallowing. I don't know if I pronounced that right, but yeah. So those are sort of 3 words to make sure that you're familiar with. Next slide, please.
Yeah.
Oh, was there not another slide?
No, I think it was just that one.
Oh no, it's coming, don't worry. Okay. Which of okay. Which of the following is not suggestive of GORD?
We got A, B, loads of B's coming in. Got quite a few B's coming through.
Yeah, great. So B is the right answer. A was the kind of the one that I was hoping that people would fall for, but B is actually the right answer. So weight loss again is a red flag symptom. So that's what I was talking about before. And these are the sort of the alarm symptoms. And if you've got weight loss, that is more indicative of a cancer. So Gourd symptoms, you get heartburn, belching, acid brash, water brash. It's like the kind of saliva in your mouth, not saliva, but you kind of get water in your mouth, or bile as well. Dysphagia, you can get as well from esophagitis, as you get the acid regurgitation, but you probably still would want to do an endoscopy to diagnose that. And then you can get these extra esophageal symptoms such as chronic cough and laryngitis as well. So the answer is B. And next slide, please. This is the slide that I was expecting before. So urgent within 2 weeks, endoscopic investigation is indicated if any of the following red flag symptoms are present. And again, I like ways to remember things. So I think of the alarms symptoms. So in anyone over age 55 with persistent recent onset dyspepsia, that by itself is a red flag, and you want to do within 2 weeks endoscopy, or any of these other alarm signs. So if they've got a new anemia or loss of weight, anorexia, recent onset or suddenly your symptoms, you've had GORD all of your life, but suddenly it's got so much worse and you can't think of why. You can get melena, hematemesis, and swallowing difficulty. So any of those things, endoscopy is the most important thing to do. And that would be 2-week rule, GI surgeons.
I think we've got a question coming in. So if it's an alarm feature, why is it not featured a feature of GORD?
What symptom are we talking about here?
As in so the loss of weight specifically.
Well, GORD isn't an alarm. So alarm symptoms are looking for cancer. So lots of people have GORD. Lots of people have gastroesophageal reflux disease, and those people might have endoscopies to monitor that. But weight loss indicates that it's not GORD and that it's something worse. So that's why it's the sort of the alarm symptom. GORD by itself isn't going to cause you to lose weight. Does that make sense? Cool.
Okay. Next question. So, which grade of esophagitis does this OGD image show? Loads of D's coming through.
Yeah. How could they possibly know this?
I was viewing this image I've just got it off Google, so I'm guessing they might have seen it. I mean, that looks awful.
Well, that's true. That's true.
So it is D. To be fair, that does look awful. So we got the Los Angeles classification here for reflux esophagitis. So we start with grade A. So this is where you have a couple breaks on the mucosal folds which are less than 5 millimeters, and they shouldn't be crossing the folds. So these here, the little kind of paler lines are the folds. Grade B over here, you'll have a few mucosal breaks which are more than 5 millimeters, but still not crossing the mucosal folds. So if I compare it to the actual OGDs here, you can see little things like specks around here. So this is a grade A, but they're not really kind of connected. Whereas here for grade B, you can see they're much larger, so it's just kind of going up here, but still they're not kind of connecting across the folds. Then you got grade C, where you've got much larger breaks, which are continuous over 2 or more of the mucosal folds, but it's covering less than 75% of the actual circumference of the esophagus. So over here, this isn't a really good picture, but you can see a bit of erosion around here. You can see some over here as well, and it's a bit dark here, but I would assume it's crossing over a little bit and connecting somehow. And then here it's just kind of almost going all the way around. So that's a grade D, where it's clearly over 75%, covering most of the circumference of the esophagus here. So, next question here. Which of these markers is not specific to the liver? Oh, loads of C's. Everyone's been paying attention to yesterday's session. So C is the right answer. So ALP. So ALP's non-specific. So it's also found in like bones, in placenta, heart, kidneys, things like that. So with anything to do with the biliary tree, it's in this bit here. So you've got your bilirubin, which will go up if you've got any kind of stone or anything blocking the bile duct. Then your gamma GT and your ALP, so alkaline phosphatase, are the ones which indicate there's something going on with the biliary tree. So your gamma GT paired with this kind of tells you it's something to do with the liver. Then you've got your AST, so your aspartate aminotransferase, and your ALT, the alanine aminotransferase. So this is like a liver test and a specific test. So these are kind of telling you there's something going on within the liver itself. And then albumin and your prothrombin time will indicate if there's any kind of functional issues going on with the liver. So next question, what is the mechanism of action of angiotensin 2? There's the C's coming through. Yep, so C is the correct answer. So well done, guys. So angiotensin 2. So if I just go through this diagram really quickly. So this is your RAS system. So if there's any drop in blood pressure or if there's a drop in the actual fluid volume, it signals your kidneys to release renin, which then converts this angiotensinogen to angiotensin 1, which then is converted into angiotensin 2 by your angiotensin converting enzyme. So this then goes and constricts the blood vessels to help boost the blood pressure itself. The other job of angiotensin 2 is to signal the adrenal glands to release aldosterone, which then in turn helps with the reabsorption of water and sodium in order to help boost that kind of fluid volume as well, again to increase the blood pressure. Next part, which part of the nephrons do Nsaids act on? Got someone saying Z here. Oh, so mostly got A's, got a C in here. Got a B. Just give it a few more seconds. Okay, so mostly everyone's put down A, which is correct. So well done. So got this of Sketchy Medicine, and they've got loads of little infographics on there, which I love. So the Nsaids constrict the afferent arteriole. So if you think about things like AKI, so what's happening here is this is constricting it, so that means there's less blood flow going into the glomerulus, so that EGFR, so the filtrate rate, goes down because there's not much going in there. It also means your kidneys aren't getting supplied with enough blood either, so that's kind of slowly leads to an AKI. Now, if you've got that going on there, and you've also, so that's your NSAIDs there. The other drugs that you need to kind of remember are things like your angiotensin 2, so, and your norepinephrine, so your noradrenaline, and AMP can cause constriction of your efferent, which can kind of reverse the effects of your NSAIDs. So it tries to kind of counterbalance it. But if you're taking an NSAID and you're also taking an ACE inhibitor or an ARB, then that can worsen and increase the likeliness of getting an AKI here. So thanks, Emily.
A 50-year-old man from Vietnam with a 40-year pack history visits the GP. He complains of a long-standing cough, fever, and weight loss. Bloods and sputum cultures are performed. He's diagnosed with TB and is started on treatment regime. Which of the drugs that are part of the treatment regime are given for only the first 2 months?
Got a few Ds, got a couples. Yeah, got a few Ds here. C, B. I'm getting a bit of a split here. Got an A, got another D.
Okay. So the answer, yeah.
I was just going to say mostly D's in here though.
Okay, so the answer is D. Well done. So do you mind going to the next two, please? Thanks. So initial phase, 2 months of all of the 4 drugs. So rifampicin, isoniazid, pyrazinamide, and ethambutol. So that's the first 2 months, and then again, the way I remember it is RIPE, which I think you got taught. And then the continuation phase is just the first 2 of those. So the rye, you continue the rye, and you continue those for the next 4 months, which is why that is the correct answer. One of the was it? No, there won't. So the other thing is, another drug that you give with this is called pyridazine hydrochloride, which would be quite a hard question, but could pop up. And this you give with the isoniazid, and it's prophylaxis for neuropathy. So if you're giving the isoniazid, you should give the pyridoxine hydrochloride as well. And then the other thing is that if you have any CNS involvement, then you do a longer course of treatment. Okay. Do feel free to just write any messages, any questions in the chat if you have any. Which of these is not a complication of sickle cell disease?
Someone just
wants to grab yeah, sure.
So we're getting a few Ds. There's a couple of E's in here, E in here.
Sorry, I'm trying to spell this. So what are they? D's, E. You're welcome.
I think it's a bit of a split here.
Yeah.
E's and E's. Yeah.
E's and D's. Cool. More D. Okay. So there is one that is not a complication of sickle cell disease, and that is D, which is hypertension. You generally get hypotension in sickle cell disease. So you can get hypotension acutely as well, which is an emergency, and that can be a splenic sequestration crisis, where you get entrapment and pooling of the blood in the spleen, and this presents with left upper quadrant pain, anemia, and you can get intravascular volume depletion, so low blood pressure. Acute chest syndrome is another emergency. So you get sickling of blood in the lungs. You can diagnose this with a chest radiograph. You get a new radio density on this radiograph, accompanied by fever, respiratory symptoms. But this is a medical emergency, so act quickly and get senior support very early, because you can get infarction of the lung tissue. So avascular necrosis was another one that was mentioned, which is where you get the loss of blood supply to the bone, which does again happen in sickle cell disease. You get the sickling of the cells, which can cause this avascular necrosis. And then priapism as well. You can get unwanted, sometimes prolonged painful erections. And again, if this lasts more than 4 hours, this is a medical emergency as well. And then stroke is really common. So I don't know if, so we were at St George's in our first year. We had a patient, somebody who had sickle cell disease that came in, and she was in her 20s, and she'd had I think she'd had 2 or 3 strokes, and she was just talking about her life with sickle cell disease. So it's really, these things really do happen, and they do really affect these patients. Okay. So 20-year-old girl goes to the GP feeling tired. On examination, just realised this probably isn't the 20-year-old girl's mouth. On examination, she has pale conjunctiva and glossitis. Blood results are as follows: HB 105, MCV 115. What is the most likely diagnosis?
Got loads of C's coming through.
Great. Very good. And can anyone tell me what I'm trying to show in this picture? Can anyone try to type it in the chat?
Got smooth tongue. And then glossitis.
Yeah, great. Yeah, so so the easiest way to know the answer to this question is that this is the sorry, what am I doing? So this is C is the only cause of the macrocytic anemia that we have here. But this tongue is, so this is glossitis. So you get swelling of the tongue, soreness, you get the smooth tongue, as you said. And this is typical in nutrient deficiencies. You can also get it as in drug reactions and in infections. But normally, if they show you a picture, it'll be this really smooth red tongue. But this is actually what you're more likely to actually see in patients. This is an earlier B12 deficiency. So A and B, so iron deficiency anemia, thalassemia, they're typically microcytic anemias, and D and E are normally normocytic, unless there's also iron deficiency anemia involved as well, which can happen with both of these things. So next question, a 2-year-old is brought into ED by her parents. Symptoms include fever, neck stiffness, photophobia, nausea and vomiting, non-blanching rash. CSF cultures were done and a gram-negative diplococci anaerobe, which is spherical, was seen under the microscope. Which organism is the likely cause?
We've got quite a lot of C's, got an A. Those are C's coming through. I think it's, yeah, mostly C's.
Cool. Yeah, so this is C. And the name sort of gives it away slightly, but this is a meningococcal rash, i.e. caused by meningococcus. But this is only about you get a rash in about half of people with meningitis. Some people say less than that. So again, don't think they don't have meningitis because they don't have a rash. But this indicates that it's likely to be this bacteria, and you can get meningococcal septicemia very quickly, which can be very dangerous. So something to definitely look out for. So on the next slide, so Nisseria Meningitis is a gram-negative diplococcus. So this is just classifying the different, I always found this really difficult, the gram-positive and the gram-negative. So you do it by shape. So coccus is circle, sphere-shaped, and bacillus are rod-shaped. And then anaerobic grows in the absence of oxygen. Gram-negative bacteria stain pink with a gram stain, and then gram positive is purple. So that can help identify it, and you could get questions asking you to identify what it is by the bacteria. So just try and learn the kind of the main ones, but I know it's very difficult. Okay, next question, me again. A 70-year-old man comes to the GP with back pain. The X-ray shows vertebral collapse. The GP decides to do some blood tests. Which of these options would be consistent with the diagnosis of multiple myeloma? This one might take a bit longer.
So getting quite a few. Got A's, got a B, got quite a few A's in here. Yeah, it looks like it's mostly A's so far.
Cool. So the answer is A. So in multiple myeloma, I don't know again if you've got ways to remember it, but I always remember crab. So the C is calcium, so you get hypercalcemia due to increased osteoclast activation and bone breakdown due to the signalling from the myeloma cells. The R is the renal impairment, so you get light chains that precipitate in the distal loop of Henle, and that's made by the malignant B cells, which causes renal impairment. You get so A is anemia. And under this under A, I also remember neutropenia or thrombocytopenia. So this is kind of the bone marrow infiltration by the plasma cells, which can reduce the number of the other cells. And that can cause tiredness, infection, bleeding, and that explains the low red blood cells and the low white blood cells. And then B is bone, so you get osteolytic bone lesions due to the increased osteoclast activity. And you can get pathological fractures and vertebral collapse as well. So very important thing to screen for. So usually take a urine and do the light chains in the blood as well. If any patient, to be honest, who is elderly has sort of well, any suspicious back pain or any suspicious bone pain, we generally add these on. I've just been a geriatrics placement, and we literally just do it for every patient. It's a bit of a screening. Yeah. So a 22-year-old lady presents to the GP with breast lump. She's worried as her mother recently had head breast cancer. No one else in her family has ever had it. She has no pregnancies. Her period started when she was 14. She's otherwise well, doesn't smoke, and drinks on special occasions. On examination, the lump is in the upper outer quadrant of the left breast. There are no skin changes or discharge. It's firm, smooth, mobile, and painless. What is the most likely diagnosis?
I've got loads of C's coming through.
A couple of D's.
Yeah. I think there's a bit of a lag on mine. The chat.
You can tell by the beeping when mine comes through. I don't know how to mute just that.
It's fine. It tells me that there's something coming through, and then it comes in a couple seconds later. I think it's mostly C's in there though.
Cool. Yeah, so mostly C's. Very good. So C again is the answer. So this is fibre adenoma. So she is a young girl. The lump is firm, smooth, mobile. Those are all signs that it's very unlikely to be a cancer. Cancerous lumps are usually irregular. They're hard, tethered. So here, the most likely diagnosis is fibre adenoma. However, the thing with breast lumps is it doesn't actually really matter at this point what it is, because you're going to send her for triple assessment anyway. Anyone with a breast lump, you'll send for triple assessment. So if this question was phrased differently and you'd say, what is the most, what would you do? You couldn't just reassure if that was an option. You have to do triple assessment, even if you think it is. You might want to reassure them as well that it's unlikely, but they should still go for triple assessment. So most common, how do you tell the difference between a fibre adenoma and a cyst in a question like this? This is a good question. So a cyst generally is softer. So that is the main, from just the symptoms, that's the main difference. But again, you can't 100% tell. So you could easily say that it's a cyst and it's a fibre adenoma, or vice versa, because they are both smooth lumps and are more likely in kind of, well, younger patients or patients without many risk factors for breast cancer. So you'd still send for breast triple assessment, and they would just deal with it then. So the most common breast cancer is IDC, and that's 70% of breast cancers. So somebody said, I think there are a couple of Ds. So DCIS, so ductal carcinoma in situ, actually doesn't really present as a lump. It generally is picked up in mammography. You can see it as a microcalcification, because by the time it's big enough to feel, it's likely to already have been an invasive ductal carcinoma. So actually, generally, ductal carcinoma in situ generally doesn't present as a lump, but instead as this microcalcification. And then B, a mastitis would be sort of painful and red, so that's quite a different picture.
So, got a patient who presents with jaundice and fatigue. There is no significant past medical history, and they're otherwise healthy. So, blood tests are performed showing deranged LFTs, including raised ALT and AST, raised unconjugated bilirubin, and low albumin. There are no significant changes in the other blood tests. Viral hepatitis is suspected. Which of the following is the correct combination that is found in the viral serology? think this one's going to take a little bit of time. We're getting a few C's so far. Just give it a little bit more time. Okay, so mostly see C's in my chat. The answer is actually A. Got an A in here. Just saw that now. So yeah, A is the correct answer. Well done. So I've got a table here just to help kind of differentiate it. So in terms of picking up an infection, you want the surface antibody to be the surface antigen to be positive here. And it's negative otherwise. So if they're been vaccinated, or if they're kind of early stages of an infection, or if they've just recovered, then the surface antigen is going to be negative. So if it's positive, then it's indicative of an infection. So the next thing you want to look at is the core antibody. So if the core antibody, so that's positive, that means there's an infection going on. And then to differentiate between the chronic and the acute is you look at the type of antibody. So if it's IgM, so like Emily said before, it's your immediate, so acute infection. And then IgG is your chronic infection. I remember it as M and A have straight lines and G and Z have a curve in there. So pair them up that way. In terms of if you've been vaccinated, then your core antibody and your surface antigen are going to be negative. And it's just the surface antibody which will be present if you've been vaccinated. The core is not used at all in the vaccine. And then if you've recovered from the infection, you won't have the antigen anymore, but you still have the antibodies present for both the core and the surface. So that's how you differentiate between if you've had a previous infection or if you've been immunized. And then the window period is kind of just saying you've been infected and it's just kind of building up a little bit right now. So there's more to it. So there's obviously like the core antigen and things like that as well. But these are the three that you should really look at to help you differentiate between these. So that's all the questions we're going through today. There is an extra 50 questions we've both written together, which is available after you've submitted the feedback form. So I'll paste in the feedback form in the chat again. Just let us know if you've got any questions.